Hello and welcome to JCO Article Insights. I'm your host, Rohit Singh, Assistant Professor at the University of Vermont Cancer Center. And today we'll be discussing the article, First Line Nivolumab plus Relatlimab versus Nivolumab plus Ipilimumab in Advanced Melanoma. It's an indirect comparison using Relativity 047 and CheckMate trials, authored by Dr. Georgina Long from Melanoma Institute of Australia and her colleagues. So as we know, Nivolumab plus Relatlimab and Nivo plus Ipi, I'm going to refer to as ipi-nivo moving forward, are dual immune checkpoint inhibitors regimens that are approved for treating patients with advanced melanoma based on the phase 2 and 3 Relativity 047 and phase 3 CheckMate 07 trials, respectively. Nivo plus Relatlimab is the only dual PD-1 and LAG-3 inhibitor regimen approved for treating patients with advanced melanoma. And Relatlimab is the first-in-class human IgG4 LAG-3 blocking antibody. Ipi plus Nivo is a dual PD-1 and CTLA-4 inhibitor regimen. So this paper basically is an indirect treatment comparison using patient-level database from these trials. And this pretty much was conducted because there's absence of head-to-head trials looking at different regimens in advanced melanoma in first-line setting. In this trial, the authors try to compare these two trials. However, it's always hard to compare two different trials, and we usually don't do cross-trial comparison. The problem is that the groups might be different to begin with. For example, one group might have younger patients, healthier patients, while the other might have older or sicker. These differences can make it hard to tell if the treatment caused an improvement or if the groups were different to begin with. In this trial, researchers used inverse probability of treatment weighting to adjust the baseline differences between the two patient groups or between these two trials. Inverse probability of treatment weighting is a method used in research to help make fair comparison between two groups when studying how a treatment or intervention works. Basically, IPTW helps level the playing field between the two groups or like two trials for this paper. So it calculates the likelihood of receiving a treatment for each person, for each patient. Researchers estimate the chance they would have gotten the treatment based on their characteristics like age, health, condition, their baseline staging. And based on that, they create weights. People who are less likely to get the treatment but did are given more weight, and those who are very likely to get the treatment are given less weight. The same is done for the group that didn't get the treatment. And then they rebalance the groups. By applying these weights, the group become more similar in their characteristics, as if everyone had an equal chance of getting the treatment. This way, IPTW helps researchers focus on the effect of treatment itself, not the differences between the groups. It's like adjusting the scales to make sure you are comparing apples to apples. The key outcomes the authors looking in this one was progression-free survivals, overall survival, confirmed objective response rate, melanoma-specific survival, and treatment-related adverse events. Looking at the results of this cross-comparison trial, first looking at the PFS, or progression-free survival, both regimens, Ipi plus Nivo and Nivo plus Relatlimab, showed similar PFS. At 36 months, PFS was 36% in Nivo Relatlimab versus 39% in the Ipi-Nivo regimen, with a hazard ratio of 1.08, indicating no significant differences. Looking at the overall survival, at 36 months, overall survival was 57% in both the treatment regimens, with a hazard ratio of 0.94, again indicating no significant differences. Now, looking at another confirmed objective response rate, confirmed objective rate was similar between both treatment regimens after waiting, 48% versus 50%, with an odd ratio of 0.91, suggesting comparable response rates between the two regimens. Looking at melanoma-specific survival, at 36 months, it was 65% versus 62%. Both treatments had similar melanoma-specific survival with a hazard ratio of 0.86. Interesting thing in this results was subgroup analysis. Subgroups showed larger numerical differences in efficacy, which favored Ipi-Nivo over Nivo Relatlimab. That included acral melanoma with a hazard ratio of 1.42 and OS with a hazard ratio of 1.72 in favor of Ipi-Nivo. Similarly, for BRAF mutant melanoma, it showed a confirmed objective response rate with odd ratio of 1.54, and same applied to mucosal melanoma with odd ratio of 1.59, and patients who have high LDH, more than 2 times upper limit. Looking at the safety and adverse side effects, Nivolumab plus Relatlimab had fewer grade 3 or 4 treatment-related adverse effects, which is 23% versus 61%, and fewer any grade treatment-related adverse events leading to discontinuation, which was 17% versus 41%, which means 41% of the patient in the Ipi-Nivo arm lead to discontinuation. However, I would like to add to that Ipi-Nivo was conducted much earlier, and at that time we were still kind of assessing and trying to understand the immunity adverse effects, how to manage them, which probably could have made discontinuation more common compared to a Nivo Relatlimab trial. By that time, we definitely had much more experience dealing with immunity adverse effects. Couple of things to mentionable in this, notably rates of hepatic and GI grade 3 or 4 treatment adverse events were lower in Nivo plus Relatlimab than with Ipi-nivo, although the onset of any grade endocrine, GI, hepatic, or skin-related treatment-related adverse events occurred most frequently in both treatment arms, and the time to was less than 3 months from randomization. So looking at all this data and looking at all this, it definitely seems like both the trials are very comparable in terms of efficacy, though Nivo plus retimab seems to have a better safety profile. This trial does have some strengths. It does use the patient-level data from 2 large, well-conducted trials, allowing for a robust comparison, and inverse weighting, which definitely method helps balance baseline characteristics, enhancing the reliability of the results. And it does lead to comprehensive assessment of both efficacy and safety outcomes, provides a holistic view of the treatments. Given all this, definitely the fact that it's a cross-comparison trial, which leads to a big limitation, as I already mentioned, like definitely 2 trials, it's hard to compare 2 trials, which can have its own inherited biases. So it has some differences, trial design, conduct, and follow-up times. Small size subgroup analysis definitely limits the ability to draw definite conclusion of those groups. There's definitely some inherent uncertainty with direct head-to-head cross-comparison trials. Looking at the future direction I would take from this trial, if we can have a direct head-to-head trial, because both of the treatments are approved in first-line setting, it will be comparing these 2 regimens that can definitely provide more definite evidence. And further research is needed to explore the efficacy of these regimens in specific subgroups. As I mentioned, in this, some subgroups showed increased benefit. Ipi-nivo regimen, however, they were very small sample size, so we need more research exploring those subgroups. One other part, in both these trials, patients with active brain mets were excluded. However, there's a phase 2 trial looking at Ipi-nivo in active brain mets patient. So I think assessing a patient with active brain mets moving forward is also be a crucial part looking at, because often patients with advanced melanoma develop brain mets. It does lead to some unanswered questions like long-term survival and quality of life. How do these regimens compare in terms of long-term survival and quality of life? While the study provides data on PFS and OS, long-term survival and quality of life metrics are essential for understanding the full impact of these treatments. Optimal sequencing strategies. What are the optimal sequence strategies for these patients who progress on one regimen? There is data suggesting that patient may respond to alternative regimen after progression, but more research is needed to establish the best treatment sequence. And real-world performance. How do these treatments perform in real-world setting outside of clinical trials? Real-world data can provide insight into the effectiveness and safety of these regimens in a broader patient population. So in summary, Nivo plus retallimab offers similar efficacy to Nivolumab plus Ipilimumab, but a significantly improved safety profile, making it a potentially preferable option for patients with untreated advanced melanoma. However, results should be interpreted with caution due to limitations of cross-trial analysis. For certain subgroups, like acral melanoma, mucosal melanoma, BRAF mutant melanoma, and patients with high LDH, more than 2 times of upper normal limit, the trial showed that there's a trend definitely with Ipi-nivo may be more beneficial. Also today, data on the use of Nivolumab plus retallimab in active brain mets has not been reported. Based on these existing data, Ipi-nivo remains a standard immunotherapy for patients with active brain mets. Further research, including direct head-to-head trials, is needed to confirm these findings and explore optimal treatment strategies. Thank you for tuning into today's episode. We hope this detailed summary of the study comparing Nivolumab plus retallimab and Nivo plus Ipim in advanced melanoma has been informative. This is Rohit Singh. Thank you again for listening to JCO Article Insights. Don't forget to give us a rating or review, and be sure to subscribe so you never miss an episode. You can find all ASCO shows at asco.org/podcast.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.